Good morning everyone. This is Dr. Azmat, Assistant Professor, Department of ENT. Today we will see an important topic, that is intracranial complications of the CSOM. This is important like examination point of view as well as the clinical point of view also. So what are the complications? List means the first and foremost and most common is meningitis. Meningitis is the most common intracranial complication of the CSOM. This is very important MCQ. And lateral sinus thrombophlebitis, extradural abscess, subdural abscess, otogenic brain abscess, and otitic hydrocephalus. So these are the six are the intracranial complications of the CSOM. So let us see one by one. First, meninges. What are the meninges? Meninges means durometer, arachnoid mater, and pyometer. Pyometer is very close to brain. Okay, these are three meninges. And what is meningitis means? The inflammation of the leptomeninges, means the inflammation of the dura, arachnoid, and pyometer. Okay, it can be due to acute or it can be due to chronic otitis media. Okay, right. You have two important types, like generalized meningitis, where you can see a bacteria in the cerebrospinal fluid, and circumscribed meningitis, there is no bacteria in CSF, but you will have all the signs and symptoms of the meningitis. Clinically, you will present with meningitis. And when it comes to pathophysiology, how infection goes means, as a general rule, already we discussed various routes and various types, how the infection goes to the cranial cavity and surrounding structures. We already discussed. This is to simplify via oval window, round window, and via perineural spaces and endolymphatic ducts, and it can be through fracture of dural tear due to a cholesteatoma, and sometimes if you have a if the disease process causing bony erosion, then you will be having a CSF leak. Through that CSF leak, the infection may goes inside. Okay. What are the symptoms? How a patient present to you? Like mainly a high grade fever, neck pain, drowsy sleepiness, vomitings, joint pains, rash, and light insensitivity, seizures, and headache. All these complaints he will be presenting. Okay. But here the most important thing is, there are two important signs. How a patient what you can elicit means, the first one is Kernick sign. Here you can see the first one is Kernick sign. What do you mean by Kernick sign? Means knee is flexed 90 degrees, okay, hip is flexed 90 degrees, right? And if you try to extend the knee, okay, in this first picture he is trying to extend the knee. If you try to extend the knee, it will be painful and it will be limited. That is called as Kernick sign. Okay, and the second sign is called as Brudzinski sign. Okay, Brudzinski, Brudzinski sign. Okay, what is this sign? Means in this, if you try to flex the flex the neck, and they will flex the knees also. Means if you flex the vice versa, if you flex the neck or if you flex the knees and hip, automatically the neck also it will be get flexed. Why? Because due to meningeal irritation. Okay, these are two important signs, Kernick sign and Brudzinski sign. These are two important signs you should write and you should remember during your examination and viva also. Okay. See, apart from this, the patient might be having neck rigidity, and there will be a papilloedema, and initially you will be having a exaggerated tendon reflexes. Sometimes the tendon reflexes may be sluggish, okay, due to time being it might be sluggish or sometimes absent also, okay. And this papilloedema usually you can see in meningitis in later stages, okay? Right. When it comes to diagnosis, you can take a help of CT and MRI. With contrast, it will be very helpful. And lumbar puncture and CSF analysis, it will give a clear picture, okay. And it gives the organism and it gives the idea about the suitable antibiotic also. And this is the chart. It is very important if you go final year and if you go intern, if you go for pre-PG entrance and DM exam also, they used to ask. Even in MRCS exam also, it is very important table. Normally the CSF pressure is 5 to 20 and appearance is normal, clear. Protein is 18 to 45, glucose is 2.5 to 3.5, and there is less than 3 WBCs. But in case of bacterial infection, the pressure is raised and it appears as turbid, and you will be having raised protein and less glucose and gram stain and increased WBC. Generally they are PM cells. And in case of viral meningitis, it is pressure is normal or sometimes increased and appearance is clear, the protein is decreased and glucose normal and gram stain obviously normal, and you will have low WBC and you may be having monocytes and PMNs. You have 10% of monocytes, okay. And in case of fungal, you will be having web formation of web appearance and remaining not much change, and you will be having monocytes. This is very important table. They used to ask, okay, what are the changes, bacterial changes in a case of meningitis, viral changes in a case of viral meningitis, CSF changes. They used to ask in the examination. Generally they ask. First you should give the medical treatment. The treatment is always with antibiotics, a very good antibiotic which covers anaerobic and aerobic organisms, and with the help of CSF culture and sensitivity you can make it. And sometimes you require to have a corticosteroids to reduce the neurological symptoms. And when it comes to surgical treatment, generally after the acute episode of meningitis, you need to take up the case for either modified radical mastectomy or radical mastectomy. Radical mastectomy is, you remove all the middle content along with the mucosa and all the ossicles you will remove, and you close the eustachian tube, okay. That is radical mastectomy. In modified radical mastectomy, generally you don't remove the ossicles, okay, right, you just clear the disease, okay. These are the two surgeries. I mean, how this surgery is performed we can see later on in operative surgery. The treatment is mainly radical or modified radical mastectomy. So it means, what I mean to say is, you should address the ear later on, okay. Yeah, lateral sinus thrombophlebitis. This is very important topic. It can be alone. They used to ask for a essay question. Lateral sinus thrombophlebitis, my favorite topic. If I set the paper, damn sure I'll give you essay question, the same, okay. So that much important. Lateral sinus thrombophlebitis. First let us see what is lateral sinus. Lateral sinus is nothing but a sigmoid sinus. What is sigmoid sinus? Let us see. You have dural venous sinuses in the cranial cavity. The first one is superior sagittal sinus, the below one is inferior sagittal sinus. These two, they form as transverse sinus. You can see in the diagram. These transverse sinus they come and they form as sigmoid sinus. This sigmoid sinus is very closely related to the ear, and this sigmoid sinus, it continues as internal jugular vein. Okay, so this is how a internal jugular vein form. Superior sagittal sinus, inferior sagittal sinus, they continue as transverse sinus. These transverse sinus, they continue as sigmoid sinus. This sigmoid sinus, they form as internal jugular vein. So this sigmoid sinus is very close to the ear, and it is very important landmark during the mastoid surgery. If you don't know this, you should not do the surgery. Okay, and during the drilling also, you may likely injure the sigmoid sinus. Okay. Here, can you see this? The blue color vessel which is very close to the ear, right? You are drilling near this. You are clearing the disease in this lateral sinus, near the sigmoid sinus. Okay. You can see in CT scan the arrow mark, which is, in the dome. You can see the jugular bulb it is. Okay. The turn of sigmoid sinus, you can call as jugular bulb, and it continues as later on it will continue as internal jugular vein. Okay, right. Here sometimes the bone between the ear and the jugular vein is not there. In that cases, you may likely injure the vein. Okay, and it causes bleed. Can you see this here? External trachanal. Here actually this temporal bone dissection I dissected, and I want to show what are the structures to you people. Then I labeled also, and I dissected in our department. Later on I can show you if you come to department. External trachanal, that is the below one is facial nerve, and jugular bulb you can see, and you can see the sigmoid sinus, the very big vessel sigmoid sinus. Okay, right. How a lateral sinus thrombophlebitis occurs. Okay, what is the pathophysiology? This is very important. Okay, the first important point is formation of a perisinus abscess. Means the abscess is related to the outer dural wall of the sinus. The sinus outer dural wall, the abscess formation occurs, and that is overlaying the dural plate, the bone above the dura, right? And slowly it is destroyed by the cholesteatoma, and then the dura is exposed. Okay. So, and then next, after that, there is a formation of the endophlebitis and mural thrombus. And this bacteria and thrombus, along with the platelet aggregation and fibrin formation, there will be formation of the mural clot. There is a very big clot, and after that, due to necrosis of the clot, and it causes formation of the intramural, means intraluminal abscess. Okay, and then after that, it will occlude the whole lumen of the vessel, and that thrombus, it may give off from that, and it may sit somewhere near the brain or somewhere in the blood circulation, and it will cause, as it contains bacteria, it will cause septicemia. Okay, so there are four main important phases. Like first one is formation of the perisinus abscess. Okay, and then second one is endophlebitis and mural thrombus formation. The third one is obliteration of the sinus with the intrasinus abscess or thrombus, and the fourth one is extension of this thrombus to somewhere and causing various symptoms and septicemia also. So to make it very simple, erosion of the sigmoid sinus plate, perisinus abscess followed by inflammation of the outer wall, endophlebitis, mural thrombus formation. It gets infects with the bacteria and propagate and increase size and occlusion of the lumen, and it forms intrasinus abscess, and it propagate and it goes somewhere and causes symptoms. So this is the pathophysiology. What are the most common bacteria you have in this abscess? Means streptococci, pneumococci, staphylococci, okay, and sometimes bacillus proteus, pseudomonas, and escherichia coli also, okay. And comes to clinical features, how a patient presents to you, okay, how a patient presents to you. The very important point one should note, okay, one should write is a hectic picket fence fever, okay. Picket fence fever. What is picket fence fever? I will explain you next slide. And second one is headache, okay. It may be due to perisinus abscess, or it may be due to increased intracranial tension, or it may be due to venous thrombophlebitis, okay. And progressive anemia and emaciation, okay, and papilledema, okay. What is picket fever? Picket fence fever is high fever and swinging types. See, can you see this fence? So up and down, okay. Chills precedes fever and temperature subsides with sweating, and again fever, again subsides. So each fever spike is due to release of fresh septic emboli, okay. So that is called as picket fence fever, okay. Here these all signs are very important, and they will be asked as 2 marks questions, and these are all signs are also important for the pre-PG entrance test, okay. The first one is Tobey air test. What is Tobey air test? It is the record of CSF pressure by manometer and see the effect of manual compression of jugular veins, okay. Means you will compare the CSF pressure with the pressure over the internal jugular vein. Normally, if you compress the internal jugular vein on the thrombosed side, means for example right side is thrombosed, okay, and if you press over that, there will be no effect on the CSF pressure. Contrary, the other side, on the healthy side, it produces rapid rise in the CSF pressure, okay, right. So that is called as Tobey air test, okay. Compression of vein on the thrombosed side, it produces no effect, okay. If you compress on the healthy side, it causes rapid rise in the CSF pressure, okay. So this is Tobey air test, right. And then see, this is a operated temporal bone which we dissected for the demonstration of the students. You can see all these structures very clearly, okay. Tympanic membrane, chorda tympani, facial nerve. See the space between there is a space between facial nerve and chorda tympani is there, okay. That is called as facial recess. Why are there? From there you will go into round window, and there you will put a cochlear implant, okay. That is later on we can see. And above the external aortic canal you can see epitympanum, means that is attic area, and you can see posterior dural wall, posterior fossa dura. Behind that you can see the bluish color structure, that is nothing but a sigmoid sinus, okay. So you are operating very close to sigmoid sinus, right. Here also the bluish arrow is showing the sigmoid sinus, okay. So the next one is delta sign. Delta sign is, you can see in a MRI where, you know, in a case of contrast enhanced MRI, you can see a delta, the arrow mark shows delta, right. It is classical for this lateral sinus thrombophlebitis, okay. Apart from this, that is Crowe back sign. What is Crowe back sign? Means the pressure on the jugular vein of healthy side produces engorgement of the retinal vessels, okay. and if you release the pressure, the engorgement will be lost. But in case of lateral sinus thrombophlebitis, in case of lateral sinus thrombophlebitis, you cannot see that engorgement. That is called as, these are all, it is called as Crowe sign. Okay. Right. What is Griesinger sign? It is invented by Griesinger. What is Griesinger sign? The Griesinger sign is, that is due to thrombosis of the masted emissary vein. The masted emissary vein is behind the ear canal, ear pinna, you can see, and due to that emissary vein thrombosis, you can see a edema. Can you see here the edema over the masted area, posterior part of the masted? So that edema, that is called as Griesinger sign. Okay, and you can see tenderness over the internal jugular vein also. When it comes to investigations, you should take the blood smear. Why blood smear? Means in case of malaria also, in case of malaria also, you will be having this kind of on and off fever, right? To rule out the malaria from the lateral sinus thrombophlebitis, you need to take a blood smear and malarial test, blood culture for the organism, and CSF analysis, okay, and X-ray mastoids for cholecytoma, and contrast enhanced CT and MRI for delta signs. And if you have a ear discharge, you should take out a swab also. Okay. See, first surgery, the treatment consists of, first, a very good antibiotic. Okay, a very good antibiotic. Choice of antibiotic depends upon the sensitivity of the organism and sometimes your hospital antibiotic policy. And the second important thing is, do a cortical mastectomy and expose the sinus. Here I expose the sinus, right? Sigmoid sinus. Can you see? I expose the sinus, and after performing the cortical or modified radical mastectomy, you should remove the sinus, bony plate over the sinus, and you should open the sinus, and any infected clot or intrasinus abscess, you should remove it. Okay. If the sinus dura is already breached and any unhealthy discolored granulation tissues, you should remove, and you pack that sigmoid sinus for a 1 week, and then you can close. Okay. And see how a sigmoid sinus is closed with the fat and muscle, right? Here you can see. And sometimes you need to require a ligation of the internal jugular vein also. It is rarely required to stop the thrombus extension, and a anticoagulation therapy also. Okay, to reduce the thrombosis and extension to cavernous sinus thrombosis. Extension to cavernous sinus. And supportive therapy. Supportive therapy is by repeated blood transfusions to support to combat the anemia and improve patient's general condition. Okay. And the complications, you can see all other intracranial complications along with this, like septicemia, meningitis, subdural extradural abscess, cerebellar abscess, thrombosis of the internal jugular vein, and 9th, 10th, 11th cranial palsies, and otitic hydrocephalus. Okay, right, these are the complications. Right. Yeah, you can see extradural abscess. What is extradural space first? Okay, if you know what is extradural space, then you can know the extradural abscess. It is the collection of pus between the bone and dura. You have durameter, arachnoid meter, and pyometer, right? So bone, skull bone, dura mater, arachnoid mater and pia. So there is a collection of pus between the bone, means the skull inner table and dura mater. Okay. So this is the space where can you see this bone and this is dura mater. Between these two there is a collection of pus. Okay. When it comes to pathology, it is due to destruction of the bone over the dura mater or the inner table by hyperemic decalcification and by due to cholecystoma and granulations, and sometimes the pus may directly in contact with the dura and spread of infection by venous thrombophlebitis. Okay, and the extradural abscess, it may closely related to dura of the middle and posterior cranial fossas. I mean, the dura may be either middle and or posterior cranial fossa, and you may be having the symptoms according to that. Clinical features, how the patient presents means persistent headache, severe pain, generalized malaise and low grade fever, and a pulsatile ear discharge. Sometimes, the abscess which is spontaneously ruptured, it may come via the external artery canal, and he will be having a relief of the symptoms. This is a CT scan. Can you see this extradural abscess, where the formation of pus between the bone and the dura mater. Okay. And the diagnosis is always, apart from the all routine serological investigations, you need to take out a CT scan. And treatment consists of antibiotics and a cortical mastectomy or MRM, modified radical mastectomy, if you have a cholecystoma, if you find a cholecystoma. Subdural abscess. What is subdural space? The subdural space is nothing but the space between the dura mater and arachnoid mater, right? So abscess, the collection of pus between the dura mater and arachnoid mater. Okay, the first two layers of the meningitis. Here you can see the subdural abscess. The diagram you can see the subdural abscess between the dura and arachnoid mater. Pathology, you know very well. Okay, the infection goes via erosion of the bone, thrombophlebitis, round window, wall window, all this, everything okay. The same pathology also, for every complication there will be, the pathology will be the same. Okay, all as we discussed earlier, the natural pathways, the pathological pathways, venous thrombophlebitis, blood-borne direct erosion of the bone, all these you can implement to any damn complication. Okay. And how a patient presents. Okay. Signs and symptoms due to meningeal irritation and thrombophlebitis of the cortical veins and raised intracranial pressure. Okay. In this MRI you can see the subdural abscess. Okay. So meningeal irritation, due to meningeal irritation you will be having headache and high grade fever, malaise, drowsiness, neck rigidity, and positive Kernicks and Bruschi sign. And due to cortical venous thrombophlebitis, the veins over the cerebral hemisphere, you will be having thrombophlebitis. It leads to aphasia, hemiplegia and hemianopia. Okay, epileptic fits also. Okay, and raised intracranial pressure, you will be having papilloedema, ptosis, dilated pupil due to third nerve involvement, and sometimes other cranial nerves also involved. Treatment. Here I want to depict one important point. If you have a raised intracranial pressure anywhere, you should not do a lumbar puncture. If you do it, there will be a herniation of the cerebellar tonsils and death will occur. Okay, so you should not do. So in subdural abscess, you do a burr holes, okay, a series of burr holes, and or else you do a craniotomy and drain the abscess, followed by a very good antibiotics I mean start preoperative only, and followed by after that you should address the ear also. Okay, so if you have a cholecystoma, you do a modified radical mastectomy. Okay, so this is regarding subdural and otogenic brain abscess. This is very, very important. Okay, 50% of the adult brain abscess and 25% of the children brain abscess are due to otogenic origin only. Okay, due to otogenic origin only. Cerebrum is more involved than the cerebellum. Okay, the pathology I need not to tell, you know very, very well. I mean the root of infection you know very well. The same, the direct extension, retrograde thrombophllebitis, round window, oval window, everything the same. Bacteriology, strepto, staph, proteus, escherichia coli, pseudomonas, and sometimes peptostreptococci and bacteroids also. Okay, here I want to tell you one important thing, that is what is Trautmann's triangle. You don't know what is Trautmann's triangle. Okay, if you know what is Trautmann's triangle, then you will be knowing what is how a infection goes to cerebellum. Yeah, Trautmann's triangle. If I am an examiner, I will definitely ask Trautmann's triangle as 2 marks. Okay, you take it as grant. The Trautmann triangle is there in your exam paper. Okay, so what is Trautmann's triangle? It is bounded superiorly by superior paternal sinus, posteriorly by sigmoid sinus, and anteriorly by solid angle. Solid angle means the angle between all 3 semicircular canals. Okay, so you can say in single word simply, the anteriorly by the bony labyrinth. Okay, so the space in between these 3 is called as Trautmann's triangle, and it is very important landmark to reach the posterior cranial fossa from the mastet. And in a single word, it is a potentially weak space or weak spot through which the infection goes to temporal bone and sometimes to cerebellum also. The cerebellum infection, it comes via the Trautmann's triangle. Okay, here what is Trautmann's triangle? You can see, can you see a very, very thin bone here in a dissected specimen? Can you see very thin bone? So if you have erosion, that bone, the infection directly goes to cerebellum. Okay, so stages. What are the stages of the otogenic brain abscess? So in pathology you should write, the first one is stage of encephalitis or stage of invasion. Invasion or initial encephalitis. Okay, sometimes it may get unnoticed, but due to symptoms are very mild. Okay, in this the patient might be having very low grade headache, low grade fever, and malaise and drowsiness. The second one is stage of localization or stage of latent abscess. Okay, here again there might not be any symptoms, and the nature or the body tries to localize the abscess. It confines the abscess to one place, that is called as localization. The third one is stage of enlargement or stage of abscess formation. The abscess begins to enlarge. Okay, a zone of edema also around that abscess, and you can recognize via the CT scan also. And the clinical features in these are mainly due to raised intracranial pressure and disturbance of the function of the cerebrum or cerebellum. And stage 4 is rupture of the abscess or termination, terminal stage, where the brain abscess, it expands and it terminates or it ruptures into the white matter of the brain and into the ventricles and subarachnoid space, and it causes fatal meningitis and death will occur. Okay, to make it very simple, invasion or encephalitis, localization, expansion or manifest abscess, termination or rupture. It takes 1 to 10 days, 10 to 14, above 14 days, and rupture it may happen at any time. These are the stages. If they ask in the examination, you have to write all these 4 stages. Without these 4 stages, you cannot get marks. Can you see there is a temporal lobe abscess? The MRI shows the temporal lobe abscess. The symptoms and signs generally are headache, nausea, vomiting. The vomitings are projectile. Why? Because due to meningeal irritation and raised intracranial pressure. And you can have papilledema and subnormal temperature also sometimes. And if you have a temporal lobe abscess, in those cases you will be having aphasia, okay, and homonymous hemianopia, means due to pressure over the optic radiations, okay. The visual field will be opposite to the side of the lesion and it will be lost, and it is elicited by the confrontation test, okay. And you will be having hemiplegia, contralateral hemiplegia, epileptic fits, and oculomotor palsy and pupillary changes, okay. See, can you see this cerebellar abscess? This is cerebellar abscess, and you will be having headaches, nystagmus, hypotonia, ataxia, and past pointing and dysdiadokinesia. So the signs of cerebellar abscess, you can be having a mnemonic like dashing, dysdiadokinesia, ataxia means falling to side of the lesion, slurred speech, hypotonia, intentional tremor, nystagmus, gait issues, okay. So here this is past pointing and the second one is past pointing, the first one is dysdiadokinesia. See, the person who is with yellow dress, he failed to do what examiner does, okay. So that is dysdiadokinesia, and the second one is past pointing. He can localize. If he in the case of cerebellar lesion, he cannot localize. It can be elicited by a finger nose test also. The treatment mainly consists of medical and surgical. Before that, how you diagnose this case? Means the skull X-rays, CT scan, and X-ray mastoids for the localization of the disease, and a lumbar puncture. Okay, but lumbar puncture you should not do if raised ICF. I mean intracranial pressure ICP. Medical management consists of high dose antibiotics parenterally, which includes anaerobic and aerobic organisms, and raised intracranial tension can be lowered by dexamethasone, mannitol, and surgery. It consists of abscess can be approached via repeated aspirations with burr holes and excision of the abscess with open method. Okay. Otitic hydrocephalus. What is otitic hydrocephalus means? It is characterized by raised intracranial pressure with normal CSF findings. Remember here the ICT intracranial pressure is raised, but the what do you call, the CSF findings, like it's pressure. I mean sorry, not pressure. It's proteins and sugars all are normal. Okay. Right. How a otitic hydrocephalus occurs means it might be due to the lateral sinus thrombosis, and the thrombus from there it extends to various places like superior sagittal sinus, various places, and you will be having a raised intracranial pressure, and the thrombus may extend to cavernous sinus also. And symptoms: severe headache. The patient presents with severe headache with nausea and vomiting. Diplopia. Why diplopia? Doubling of the vision. Why? Because due to palsy of the sixth cranial nerve, and blurring of the vision due to papilledema. Okay, and you will be having nystagmus and lumbar puncture. Generally you should not do, but the pressure is usually high, and the treatment consists of to reduce the CSF pressure. If you don't reduce that CSF pressure, you will be having optic atrophy and blindness. It is achieved by acetazolamide and corticosteroids, and in these cases a repeated lumbar drain. If you put a lumbar drain, it may causes drop in the pressure. And middle ear infection you should address with the antibiotics and exploration of the mastoid or modified radical mastoidectomy in case of cholecystoma. Okay, so this ends my topic, and it ends intracranial complications. Thank you very much.